So it gives me great pleasure tonight this is our first monthly Rudasa Rural webinar. As you all know, probably we have the very intensive 8 weeks in February and March with weekly webinars to help orientate our new rural doctors. And there's been such a request for actually ongoing webinars throughout the year. And I think the big thing we like about the webinars is they all get recorded. They're all available on the website. We know not everybody can actually get there at the night, especially in the evenings when we're all exhausted. But this will be available as a resource for doctors in our rural facilities. And tonight, it's very lovely to be actually covering one of our medical topics. And I'm proud to introduce Prof Mike Levin, who is head of the Asthma and Allergy Unit in the Department of Paediatrics at University of Cape Town, as well as the Red Cross Children's Hospital. And he teaches medical students and professionals in allergy, presents at the national and international allergy congresses, and has a special interest in the epidemiology of allergy in Africa, severe allergies, anaphylaxis, and patient support and education. And although he's a pediatrician by background, I think we will find a lot of overlap also with some of our adult asthmatics. So thank you very much, Prof Levin. I'm going to hand over to you. Just a reminder for those of you that are attending, also if you're on YouTube, to please put your name and your MP number in the chat, or your so that we can capture that for CPD purposes. Thank you very much. Prof Levin, over to you.
Thanks so much, Madeleine. And I must say, it's really I'm very happy to be here and to be chatting to you guys. I've got a great soft spot for rural medicine and for primary care. And even though I'm a pediatrician, I consider myself, and a subspecialist in allergy, I consider myself very lucky actually to be working in an area that is very common in primary care and is managed predominantly in primary care, and requires a lot of the aspects of kind of primary care approach in order to manage appropriately, not only knowing about the condition and the drugs, but also dealing with the important issue that we're going to be tackling today, which is really talking about optimal aerosol delivery as the main route for asthma control. Because we all know that asthma is an inflammatory disease, and we need to address that issue of inflammation. That is why we have regular controller therapy for asthmatics, given every day, whether the person is symptomatic or not. And in addition to that, there's the reliever therapy, which is aimed at the bronchospasm, which is given only for people when they're having their exacerbations. And in fact, although I'm not going to spend time in the talk talking about asthma guidelines and medication, I'm quite happy to take discussion later during the discussion. There have been major changes in terms of the way that we approach asthma nowadays, with it really now being essentially forbidden to be giving any adolescents and adults reliever therapy on its own without controller therapy at any level of asthma treatment. And this is unlike the previous guidelines where we used to say intermittent asthmatics do not need regular anti-inflammatory therapy. The new guidelines published in 2021 from GINA and have been slowly adopted across the world, and hopefully will be in the essential drug lists and all the guidelines very shortly, are that every single asthmatic, regardless of the degree of severity of symptoms, needs to have controller therapy of some degree. But no matter what that therapy is, whether it is therapy aimed at inflammation or therapy involved at bronchospasm, it needs to be delivered as effectively as possible to the major site of the pathology, which is clearly to the airways, and not just the airways, the peripheral airways, as far down as possible. And the major medications that we use, you can see just some kind of random examples that I chose, are of the medications that are delivered directly to the lungs. So what you can see on the top is a couple of different devices that are used as dry powder inhalers. The two that you see on the top left, the Symbicort and the Foxair, also comes in a generic called Seretide, it's called Seroflow, are long-acting beta-2 agonists in combination with inhaled corticosteroids. And these are the mainstay of treatment of higher levels of therapy of asthma. The dry powder inhaler that you can see, the DP caps, that is delivered through the device on the top right. It's a simple capsule that you put in there and crack it open and then inhale that dry powder, is a inhaled corticosteroid. And we all know that in the public health service, we have access predominantly to budesonide and or beclomethasone, both of which are excellent and effective corticosteroids. They do have some systemic bioavailability, which is a problem. And that is also why delivery to the airways is so important with these medications, to prevent the oral administration and the systemic absorption that is associated with some of the older medications. Then you can see on the bottom an array of a couple of the different metered dose inhalers. You can see 3 in the middle have a very normal shaped nozzle. That is the standard nozzle that fits into the normal inhalers. The one on the far left is ciclesinide, which has this strange round nozzle, which is an unfortunate design in that medication because it does make it more difficult to get optimal aerosol delivery. And then in the bottom right-hand corner is a breath-activated metered dose inhaler. So as you breathe in, it automatically triggers and releases a puff of the medication. And clearly that is only designed for use in the mouth, because when you use a spacer, you cannot generate that flow in order to activate the inhaler. So there are a lot of different medications that we have, and unfortunately, each of them has its pros and cons, and each of them needs to be used in a different way in order to allow the medication to have its best possible effect. And what you can see here in the kind of the graphic is where the different deposition of the medication goes to, depending on which type of device that you're using. So starting on the left with the metered dose inhaler on its own, you can see that only 9% of the medication is delivered to the lungs. The vast majority of what's left over, 81%, is left in the oral cavity, where it is possibly absorbed and can cause local side effects in terms of thrush. There's a very little bit left that's behind in the device and a very little bit that's exhaled. And if you look at on the opposite side at the dry powder inhalers, you can see the stripes are pretty much similar in that there's slightly more deposition to the lungs with a dry powder inhaler. But again, the vast amount of the stuff that's left behind goes to the oral cavity, but a little bit more stays behind in the device. When, however, you take a metered dose inhaler and you use a spacer, you can see that that blue stripe dramatically increases to 1.7 times what it is without the spacer. So you get about 15 to 16% of medication that goes into the lungs. And this is the highest amount that can be delivered into the lungs. And as you can see, is higher than that is delivered by a nebulizer. So the advantages of the spacers are that you get better delivery to the lungs and reduced oropharyngeal deposition. So you have increased efficacy and decreased side effects. So those are the major advantages. Well, the major advantages of a metered dose inhaler on its own without a spacer is that it's small, it's portable, it's quick, they're relatively cheap, they're easy to clean, and in fact, they are more effective than most nebulizers or dry powder inhalers when you compare dosage for dosage. And I'll speak about that in a little bit of a while. But the problems are is that spray comes out really, really quickly. Comes out so fast that it's like within milliseconds, it hits probably about almost a third of a meter. So it's very, very difficult to inhale that spray into the lungs in any kind of reasonable way. And problems that you can have that make it even more problematic in terms of drug delivery, or if there's people forget to shake the metered dose inhaler, or if they breathe in too early, or they breathe in too late, or they indeed press the pump in too early, or they press it too late. Because for metered dose inhalers without a spacer, you need to have excellent hand-breath coordination. What you're trying to do is to breathe all of the medication, all of your stale air, all of your dead space out of your lungs as much as possible. And then just before you're about to press the pump, you start breathing in, press the pump just after you start breathing in, and then continue breathing in slowly, but very, very deeply to full inhalation. Hold your breath for 10 seconds and then breathe out through your nose. So if you are trying to coordinate this pressing of the pump with your breathing, if you press too early and you haven't started breathing yet, then all of that spray essentially hits as a jet into the back of the throat and hardly any of it goes into the lungs. And if you press too late and you've already breathed in some air, then you've got more dead space that's in your lungs, and the deposition of the aerosol spray is to your large airways rather than to your small airways. Another problem with metered dose inhalers is the speed at which you breathe it in. If you breathe in very, very quickly, you can see there at 80 liters per minute. This is a radionuclide labeled picture of spray that's being delivered into the lungs. And when you breathe in very quickly, you have this turbulent flow that develops, and the medication is spun out of the laminar flow, and instead of landing up deep in the lungs, lands up in the trachea and the first or second divisions of your main bronchi. And if you have lower flow and you breathe in much more slowly and very deeply, that's when you achieve some peripheral deposition. So the speed at which you inhale the medication is really very important in terms of how much gets into the lungs. So I've discussed this already, how to breathe. Breathe out completely, start inspiration very slowly, follow as soon as possible by actuating your device, a smooth, slow, and long inhalation with inspiration to full lung capacity, holding for 10 seconds to enable those particles that have reached your peripheral airways to be deposited, and then breathe out through the nose, preferably, in case there's any steroid left over, and then hopefully you'll be able to treat the person's concomitant allergic rhinitis with a little bit of the leftovers at the same time. So here are two pictures of kids using metered dose inhalers, and I think the major point that you need to kind of take away from this is that neither of these kids really should be using this device at all. Certainly that little baby is far too young to be using a spacer in the mouth, and even the kid in the graphic with a green t-shirt is probably unable to breathe in the metered dose inhaler without a spacer in any effective way whatsoever. And we know that kids can't use MDIs because of the high speed of aerosols, the poor coordination, inadequate breathing out, this tendency to very rapid inhalation, inadequate breath holding techniques, and these mistakes reduce the clinical effect so much that MDIs without a spacer should never be used in at least children 6 to 8 years, but I would say 8 to 10 years, in fact. And it's a misconception that spacers are only for children, because in fact, adults, particularly adults with moderate to severe asthma or on level 3 or higher therapy, really want to give you really want to get the maximal benefit from your medication and have less side effects, so they could benefit from using a spacer as well. So I'm going to see if this video will play, and it'll go over some of the messages, hopefully, that we've already discussed.
Asthma pumps, metered dose inhalers, must be used with the best possible technique to get the medication deep part of your lung. Although asthma pumps can be used on their own, adding a spacer to the front of the pump makes it a much more effective way of getting medication to the lungs. All children and most adults with problematic asthma should be using their pump with a spacer. There are 3 different ways of using an asthma pump, depending on the person's age and their capabilities.
So this is just one example of the type of videos that we have available on the internet, on the Allergy Foundation of South Africa website, where we really do focus on both patient education and also doctor education in order to facilitate their patient education. So there are these videos as well as action plans for asthma and guidelines and all sorts of information that may be useful for you guys. So let's talk a little bit about spacers. Spacers are simply an additional volume in which the medication can be dispersed before it's then deposited into the lungs. So they have this effect where they increase lung deposition, prevent oral deposition, but they're very much underused. And one of the problems that we've addressed recently is the fact that commercially available spacers up until now have been potentially quite costly, ranging from 130 to 150 Rand for the cheapest spacer, all the way up to 700 Rand for some of the more expensive ones. So that is a barrier to their use by patients in the private health sector, and also they are very much underused in the public sector, partially due to lack of understanding of their necessity, but also due to the cost. So there are different sizes of holding chambers. 200 mils is adequate for kids, 500 mils is necessary for older children and for adults. And there are both non-valved spacers or simple holding chambers, and a valved spacer which prevents the air that you breathe into the spacer from coming out while you still have medication in there. But it's really important that the techniques by which you use the spacers differ, and that's why we need to focus very much on making sure that you have the right device for the right person and the right technique. The non-valved spacers provide a little bit of protection for poor hand-breath coordination, but you still have to concentrate on the speed of the breathing and the smoothness of the breathing. And when you're using a non-valved spacer, in order to get the best lung deposition, you can use the one-breath technique, which is almost exactly the same way as somebody uses a pump in their mouth. And it's important in this case that you can still advise to start the inspiration just before you actuate the meter-dose inhaler to make sure that you don't have lots of additional dead space in your lungs and there isn't a delay before the medication goes in. But you can get lung deposition that is increased by greater than 50%, in fact, up to 70% by using a spacer in this way. Non-valved spacers in terms of low-cost spacers have been used for a very long time. And I'll tell you a little bit about what Prof Heather Czar designed at Red Cross Hospital. But it's also important to note that the low-cost spacers that are shown in this picture where they are reversed backwards are not effective because you can never get a seal around the mouth on the base of a pump. And the pictures of people, putting the pumps in the mouth of the cool drink bottle or cutting it off and then putting a plaster around it really are completely ineffective methods of aerosol delivery. And same goes for a polystyrene cup, which is used in some places, but actually doesn't have any efficacy at all. So things that you need to tell your patients about using a meter-dose inhaler with a spacer is that you need to have a single puff in the spacer with each breath. Because if you put multiple actuations into the spacer, first of all, if you haven't shaken it, there's a small decrease in the dose that comes out the second time. But most importantly, the droplets stick together and to the holding chamber and go onto the side. So instead of getting 2 doses, you essentially only get 1 and a little bit. So every single puff must be given separately. Then the person takes the pump out, shakes again, puts it in again, and gives another puff through their spacer. So a single puff at a time, again, full exhalation, single breath inhalation technique, holding the breath and out through the nose. The similar way to use a spacer, a meter-dose inhaler without a spacer. So I'm going to tell you a little bit about the bottle spacers that were developed originally by Prof Heather Czar, who is our former head of Department of Pediatrics and Child Health. She now heads up the SAMRC unit on child and adolescent health. And she's won a number of awards for her basic background in pediatrics and in pulmonology, but also in terms of the development of the spacer, and also published quite a lot of information on the use of these spacers in the delivery of medication, including a randomized controlled trial on acute asthma, which showed equal effectiveness of using a homemade bottle spacer with commercial spacers. And you can see some of the original versions of the bottle spacers that were used up until recently. But in 2020, when COVID hit us, we published an article that basically said, as part of a World Allergy Organization guideline, that we should stop using nebulizers for therapy for acute asthma, because we know that delivery of medication with metered-dose inhaler and spacer is as effective as using an asthma pump, and in fact, reduces the time that is taken in the delivery room and subsequent admission. So we realized that we wanted to rapidly make more medication available, or more devices available, spaces available to patients, and simply using the bottle spaces that we had was not scalable to the amount that we needed. So the first thing we did is we devised this technique of cutting a hole into the base of a bottle, as you can see in the middle there, instead of burning the hole into the base of the bottle, which was done with the previous low-cost spaces. And then later, we developed the idea of actually blow molding the spaces as they come off the machine, so that we essentially make them in the shape of this little nubbin, and then that nubbin gets cut off, and the shape of that is exactly the same shape as the nozzle of the metered-dose inhaler. We automated that process by using this little electric drill kind of thing, and we put labels on them, labeled by the Allergy Foundation, and we gave 100,000 of these low-cost bottle spaces to the various different provincial departments of health in order to rapidly allow the use of low-cost spaces throughout all parts of the country. So that's what we did with the COVID pandemic. But one of the problems that we noted with the first version of our spacer is that there was no valve that was associated with that. And valve holding chambers are better in many patients than non-valved holding chambers, because they give you the best protection against poor hand-breath coordination. They can still be used with a single breath technique, but with a valved holding chamber, you can also do 6 to 10 breaths deep, slow, tidal breathing into the spacer in order to get medication deeply into the lungs. And that is the technique that you would have to do in the majority of children. So we wanted to look at solving that problem long-term, and we used the funding that we had been given by Elmer Philanthropies to then develop the second generation of the AfriSpacer, which is that one that you see on the bottom right with AFSA on the side and with the valve, the blue valve on the front. The people who were involved in that, this is a team of biomedical engineers who were master's students of mine working on a different project to do with injectable adrenaline. And they, first of all, helped devise the cutting tool, and they took a huge amount of work off by improving the cutting of the little nubbins off the base. And they were the group who designed the Afri valve, which you can see is a really very, very simple but very elegant flap system made by two pieces of injection molded plastic and a single piece of die-cut silicone in between that are then glued together. And that makes an absolutely wonderful, effective valve. When you put that together, that was one of the prototypes. You land up with the gadget that we see there. And the initial graphic of the base of the AfriSpacer can be seen with a picture that I took yesterday of the base. You can see the little aperture for the spacer is the same size as all of the other commercial spacers and has those little ridges of it, which makes it flexible and able to take all the pumps very, very securely and easily. So let me show you a little bit about the AfriSpacer and some of the techniques and why it's needed.
Now below, you need to use a spacer to get the medicine to work properly in your lungs.
Inhalers contain the medication needed to treat your asthma, but the medication must be delivered to the lungs. The AfriSpacer is a spacer device which slows the speed of the spray down and helps you to get more medication into. Spacer is recommended for all children and for adults with difficult to control asthma.
Remember what I said below?
I shake my palm and put it in the back of my spacer. I put my mouth over the valve.
Make sure the valve is between your teeth and your lips are tightly closed so nothing leaks out. Are you ready below? Okay, now breathe slowly and deeply all way in and all way out. 6 times below. Well done.
My friend showed me this cool little gadget for my asthma pump. You don't have to push down, all you have to do is squeeze, and it's amazing for little kids younger than me.
The AfriSpacer is recommended for all children and for adults with difficult to control asthma. The AfriSpacer can be used in 2 different ways. Younger children can use the AfriSpacer with the one-way Afri valve and breathe in and out 6 to 10 times to get all the medication in the lungs. Adults and older children can use the spacer by breathing in all the air inside with one breath with the valve off.
I didn't know adults should also use spacers, but since I've been using my pump this way, I have better control over my asthma.
Shake the inhaler to ensure that the contents of the inhaler are well mixed. Fit the inhaler firmly into the AfriSpacer. Place the mouthpiece in your mouth between your teeth. Close your lips firmly around the mouthpiece, but do not bite it. Breathe out as far as is comfortable. Press down firmly with your fingers on the top of the inhaler to release one medicine. Straight away, take one deep, slow, steady breath to make sure that the medicine goes into your lungs. You must inhale one medication at a time and hold your breath for 10 seconds. Breathe out through your nose. If you need to take more than one puff, remove the inhaler, wait 30 seconds, and then repeat.
My doctor gave me an action plan to control my asthma. I've got 2 pumps, and the plan helps me remember which I must take only when my chest is tight, and which I must take every day.
For more information about the AfriSpacer, go to www.
So I think that what you can see is that there's a lot of information that we need for our patients in order to get them to use these devices in the best possible way. So we do need to take some time to educate them. And some of the rules that we have in our clinics and that we advise for most people is that when you have people with a disease that needs to be taking a device of some sorts, is that they are told to bring them with them to every single visit and to demonstrate the technique to you so that you can actually check it in real time and check to see whether it's being delivered by the best possible technique or not. So let me now address the issue of spacers with masks. So very young children, those under about somewhere between 2 and 4 years of age, need to use a mask with their spacer, and they need to use a valve holding chamber because they are breathing in and out. And although many people believe that the mask in general helps with deposition, it only actually helps with deposition in very small babies who are unable to put a mouthpiece in their mouth and create a seal and to breathe in and out through the mouthpiece. Because the mask gives you an additional dead space. Poor fit of the mask is often a problem. And if there's a little bit of a poor seal, then there can be insufficient negative pressure to open the valve and lots of leakage of air around the side, which leads to very, very little air delivery. So it's really important to stop using a mask as soon as possible. And that is why we made sure that, first of all, we didn't even sell a mask with the AfriSpacer, but we decided not to have a mask that was permanently attached to the front of the spacer, because that really does decrease its effectiveness at really the age of 3 and above. And this is the data that shows that when you put even a tiny hole in the side of a mask, simulating a poorly fitted mask that may be leaking a little bit through a poor seal on the face, that you have dramatic and very rapid decrease of the lung deposition, even with very small leak sizes. So spacers and masks are used in infants who cannot use a spacer in their mouth. And there's some important tips that we have for helping mothers to give a young children their medication while using a mask.
The way a baby comes is with a spacer and a mask. The mask is needed because the baby can't close their mouth over the spacer. This makes it easier for the baby, but not for the mom. He has to make sure that the baby is calm, that the mask is fitted tightly over the face so that the air can slip in and outside.
So look at how she's holding the child and the mask with one hand on the face so that the mask and the face are being held together with one hand.
Mask doesn't actually make the pump more effective. It's just that you have to use it if the baby can't close their mouth over the mouthpiece of the spacer. As soon as the child is able to form a seal around the spacer with their mouth, you can lose the mask, but remember to keep the spacer. The spacer is the really important part.
So I hope you were able to see on that video the technique of holding the child's face and the mask at the same time from behind, so that even if the child moves around, you've got a firm grip on both of them, as opposed to holding the spacer from the front against the child and then chasing the child around the room while they're struggling to get away. I think we saw that. How do I go to the next slide? There we go. So let's quickly look at dry powder inhalers. Dry powder inhalers are also portable and quick. They need to be held in the right way. So you, when you click your turbohaler, for example, you want it to be facing upwards. You don't want it to be sideways, because essentially there's a little capsule of dry powder in there. When you click it or you change the lever in some way, you pierce that capsule, and then the powder falls into the delivery part of the device. So you have to have it in a vertical position when you activate it. You don't need to shake them. It's very important not to breathe into a dry powder inhaler, because then you make the powder wet and it'll clump and it won't be delivered into the peripheral airways. And one of the problems that we have with dry powder inhalers is because there's no propellant in the inhaler itself, the force that is required to get the medication out is generated by your own inspiratory flow. So a higher inspiratory flow is required. And that is a problem for kids that are young. And I've seen children, very, very young children, being prescribed dry powder inhalers completely inappropriately. And it's also a problem with using a reliever medication with dry powder inhaler, because clearly when somebody has a severe asthma attack, it's very difficult for them to deliver that inspiratory flow to get the medication out of the device. So let's look at some of the tips to teach your patients about how to use a dry powder inhaler.
Using a dry powder inhaler is extremely simple. It requires the person to breathe in hard, so it's only suitable for older children and to use the inhaler, you need to load the inhaler and the twist inhaler are loaded by twisting. The actuator, aerolizer, and the ellipter are loaded by clicking the levers.
Breathe out without the inhaler in the mouth so the dry powder inside the device does not get wet. Then, when your lungs are completely empty, put it in your mouth with the lips tightly sealed and your tongue out of the way. Take a strong, deep breath in until your lungs are completely full, and then hold your breath for 10 seconds. Easy.
So very simple devices to use, but they do have this problem that they are more suitable for older children and for adults and not really for acute asthma. So let's finish off by talking about nebulizers. Nebulizers suspend a liquid as an aerosol by putting a jet of high pressure, either air or oxygen, through a liquid, which creates a negative pressure behind that flow and then rips the little molecules of the liquid off the surface and suspends them as particles in the air, with exactly the same principle that is seen when you see water vapor being created behind the jet stream of an airplane. So you need a decent flow in order to generate fine particles. And I think you'll all have had the experience of putting a nebulizer on and hearing this very low kind of noise and seeing the particles go up out of the nebulizer, but then slowly settling down and going towards the floor, and then putting up the flow to at least 6, but preferably even 8 liters per minute. And at that stage, the sound that comes out of the nebulizer will change to a much more high-pitched kind of noise, and you'll see the much more fine particles being visible and floating away on the breeze, as it were. But I think that you can appreciate that even if you have those better particles, they are still always visible. And the reason that they are visible is because they are not as fine particles as are available through a metered dose inhaler. And that is why nebulizers are actually not as good a delivery device as a metered dose inhaler with a spacer. The other problem with nebulizers is that there's always a dead space of at least 0.5 ml to 1 ml that is left behind in the cup of the nebulizer. And that is why the full volume should be 4 to 5 mls. And for example, when you're nebulizing somebody with mild asthma, you may be using 1 ml of salbutamol, 1 ml of ipratropium bromide. You must always add that 2 mls of saline as an extra volume to get that medication into the person. Just as an aside, with people who have severe life-threatening asthma and in whom very little of the medication is actually going into the lungs because they are so tight, you can simply use neat salbutamol with neat ipratropium bromide in your nebulizer without any need for any saline whatsoever, because you cannot possibly give an overdose of the medication if hardly any of it is getting into the lungs. These are in those patients who have a silent chest or who are not responding to a normal dose of nebulizer and in whom you are thinking of moving on to systemic therapy. It's a very, very useful way of trying to cut that and stop that from happening. Also, it's important that mouthpieces should be used when possible. We have this tendency of always giving nebulizers via masks. It's clearly much better to have a T-piece and it being given into the mouth when all of the inhaled medication is going at least into the oropharynx and then into the lungs, rather than onto the face and then through the nose and, not necessarily going as directly as it could. And another really important hint, particularly when treating acute asthma, is even if the patient is very distressed, just trying to get them to calm down as much as humanly possible and breathe as slowly and deeply in and out through their mouth enables much more of the medication to be delivered, which again could make the difference between progression of an asthma attack and resolution. So I spoke to you about how using a metered dose inhaler with a spacer is actually more effective than using a nebulizer, and about how this was one of the major reasons why we wanted to produce more spacers during the COVID pandemic. And this is what we do with multi-dosing. In small kids, we give somewhere between 2 and 6 puffs. For older kids, somewhere between 4 and 10 puffs. And for adults, 10 puffs is routine. 1 puff at a time in a spacer, allowing at least 6 breaths per puff if they're doing tidal breathing, and shaking the inhaler between each puff. And this has been shown to be actually more effective than using a higher dose, actually, of medication as delivered by a nebulizer. If you think about it, the reason that we like nebulizers is because they can, in hospital, be used with oxygen as opposed to with air, like home nebulizers are. And we can mix both the short-acting beta-2 agonist and the anticholinergic in the same device at the same time. So you have concomitant delivery of a sympathetic agonist and a parasympathetic antagonist at the same time, which allow you to get the best possible bronchodilation. But because the delivery is poor and because the particle size is so large, you'll be very familiar with the dosage that we use for salbutamol in a nebulizer, which is 2.5 milligrams in kids and 5 milligrams in adults. And if you compare that with a puff of salbutamol with a meter dose inhaler, which is usually 100 micrograms, you can see that in fact, when you use a nebulizer, you're using either 12.5 or 25 times as much per delivery than you are of a puff of the meter dose inhaler with a spacer. And that is why patients and many people in emergency units think that it's a more effective delivery system, because clearly it does work. But in order to make it work, you have to really use very, very large doses, as opposed to the very small doses that are used when you multi-dose people with a meter dose inhaler and spacer.
When you are having an asthma attack, it's important to be able to get as much medication as possible into your lungs. Two ways of doing this are either to use a normal asthma pump or a nebulizer. Many people believe using a nebulizer is better than an asthma pump. However, the real difference between the two is the very high dose of medication in the nebulizer. To give enough medication with an asthma pump, we use what we call multi-dosing, using 6 to 10 puffs of the pump over the course of a few minutes. Each puff must be inhaled separately and as effectively as possible, using a spacer and with a long, slow breath. Then you wait about 30 seconds to a minute while you shake the inhaler again and get ready for the next one. Repeat this 6 to 10 times and the effect will be at least as good as a nebulizer.
When you use a nebulizer in hospital, it is powered with the oxygen, not with air. The life-saving oxygen is why we use a nebulizer in hospital. A nebulizer used at home doesn't have the same effect and can easily be replaced with multi-dose.
When you use a nebulizer, breathe slowly but deeply. Short, shallow breaths will not allow the medication to get into your lungs. When you are having an
Okay, so we've discussed this, the insufficient flow sometimes for optimal aerosolization with home nebulizers, the fact that there's no oxygen, but you can also get both bacterial and allergen contamination. And we had a patient who had cockroaches and their eggs in the nebulizers and in the tubing, which was causing severe reactions because they were actually breathing their allergen directly into their lungs. And also importantly, they do give patients this false sense of security with the possible of delayed presentation to healthcare if they think that they've got the same treatment at home that they're going to get when they get to hospital. But there are some advantages of nebulizers. They can be used with tidal breathing. They're easy to use when somebody is sick. They can be used at any age. They can be used in people who are uncooperative and sleeping, although clearly the deposition is suboptimal in those situations. But the very high drug doses are possible, and mixing medications is possible. So that is why for higher severities of asthma with life-threatening asthma, we still do recommend that nebulizers should be used with full infection control measures being in place. But there are disadvantages. They're less portable, more time-consuming, need equipment, a power source, they're more expensive, they're less effective, and there are infection control issues, and they clearly have the poorest adherence if they are used as controller therapy, which fortunately is not common in our country, but is used for controller therapy in some parts of the world. So in terms of choosing a device, we need to think about which devices are available that deliver the desired drug, because there may be different types of devices for different types of medication. And importantly, can the same type of device be used for all the drugs that are required? Is the device available appropriate to the age and capability of the patient? And specifically, I'm talking about avoiding dry powder inhaler in children. Is it covered either by the medical aid or is it available in the public sector? And then importantly, which devices do the patient or parent prefer? Because one of the key aspects that we talk about with asthma therapy is adherence. And if you manage to get a concordance between you and your patient and enter into a contract with them with something that they like and that they've agreed off their own volition to do, you have a much better chance of them actually using their medication appropriately, as opposed to just giving them a device that you like and telling them, okay, use this every day, whether you are sick or not, without explaining to them why that's required and getting their buy-in in the first place. So metered-dose inhalers and dry powder inhalers are more convenient and provide lower cost per dose than nebulizers. And in general, we recommend for very small babies a metered-dose inhaler with a valve holding chamber and a face mask. For smaller children, but not infants, lose the mask. When they get older, try to convert them to a single inhalation technique. And then in older children and adults, a metered-dose inhaler with a holding chamber with a single inhalation technique, or a dry powder inhaler, or if they're exceptionally well controlled and lower stages of therapy, then and only then a metered-dose inhaler used on its own. So again, a plum for the Allergy Foundation for all of the patient training and education materials we have there, particularly with respect to our written action plans. And we are launching the AfriSpacer commercially, and we've actually applied for a state tender as well. They are very, very useful spaces. Spaces are underused and should be used much more commonly in your patients. So please try get hold of them if you can. For people in private, they are nappy coded and are available on medical aid and are only 90 Rand as the single exit price. And they have all the benefits of the spaces and are as effective as any other commercial spacer, and in fact are better than some of the spaces that have got either low volumes or non-removable masks. We will be running a Medical Chronicle webinar on the 15th of May at 7 o'clock, where Professor Anissa Vanker will be talking a little bit more about optimal airway aerosol delivery in a slightly different way, and I'll be talking a little bit more closely about the spacer and about the history. And then we've got a Facebook Live event that is actually aimed at patients, where we've got Florence Masebe, who's an asthma sufferer and a Muvango star, Riyad Musa, the doctor, a comedian, and Prof Heather Zar, myself, and the biomedical engineer who designed the valve, all talking to lay people about the AfriSpacer, and that's on the 31st of May at 7 o'clock. So I'm done, and I want to know how we're going to take any questions.
Great. Thank you very much. What I'm going to suggest that people who want to put questions in the chat can do that. Otherwise, you can also put your hand up and I will sort of navigate the different questions and see what's there. I'm just having a look and seeing if there's any questions that's come up so far. Just a reminder for those of you out there to please add your names and MP numbers for CPD purposes in the chat so that we can get those and load that for you. I'm not seeing any questions yet. Hold on, there's a message. No, not quite yet. I did want to emphasize, you mentioned it at the beginning, and I think it's one of those messages that's not come through, and it's actually in the EML, this that we're no longer giving, nobody shall have salbutamol inhaler on their own anymore. And somehow that's still a habit, especially from the clinics, that you'll still get people who arrive with their little blue inhaler. And especially this idea that in your mild, your step 1 asthmas, that you still can give them their brown inhaler or their beclomethasone, but they're actually going to take the beclomethasone after they've done their, so every time they're short of breath, they'll take their blue and they'll take their brown.
Yeah.
And I think what for me is important about what you're explaining here is the use of the nebulizer to get also your controller in properly. Quite often we're focusing on the acute scenario with the blue, but I think quite often we're struggling to get control because they're not getting their beclomethasone into their lungs.
Yeah, absolutely, Madeleine. You're absolutely correct, is that the regular controller therapy is far more important. And the educational problem for us is that because our patients don't actually feel better from it, they don't realize that it's the anti-inflammatory medication that is more important than the reliever medication. And that's why whenever we talk about the allergic diseases, we talk about the 4 pillars of treatment. We talk about patient education. We talk about avoiding their irritant triggers for everyone and relevant allergic triggers that have been proven for people who have severe enough disease to require that. We talk about the medication and the various different options. And then we talk about manipulation of the immune system, which can be in the form of immunotherapy or the new biologic therapies for the very, very severe, the most severe. But coming back to that change in the GINA guidelines, it's absolutely critically important that people don't prescribe simply short-acting beta-2 agonists on their own. And certainly in the pediatric world, that's a little bit of a problem because clinical nurse practitioners may not be either comfortable with, or indeed it might not be within their scope of practice or within their written guidelines to be allowed to prescribe inhaled corticosteroids at all. So that does really create a disconnect. The GINA guidelines that say that you must use a controller therapy for every patient do only apply from patients who are 18 and above. But certainly the data in the younger children is still being developed. And it seems very, very likely that that age range will be dropped in the course of the next couple of years as the data really comes in. So I think it is something that we really need to address not only with our nursing colleagues, but also with our regulatory colleagues and with our provincial health people to make sure that there is widespread availability of inhaled corticosteroids absolutely everywhere in the country.
Yeah, that's very helpful. Interestingly enough, we do have, I'm at a regional hospital, but according to at least the hospital guidelines, we're supposed to have access to the salmeterol fluticasone preparations.
Yeah.
And that's quite nice because it also comes as an MDI, so you can do your spacer thing. The other thing we have also available is the budesonide formoterol on the sort of tertiary hospital, and I think the district hospital might even have access to that. But then you have the challenge that you can't use the spacer with that. So you basically just
so let me address that in a little bit more detail, because those medications, although they're both long-acting beta-2 agonists, inhaled steroid combinations, are actually completely different. And one of the problems is that many of us do appreciate that difference, but the pharmacists and the regulatory people often simply exchange one for the other. So you could, one day you could be getting a fluticasone salmeterol with a metered-dose inhaler, and the next day you're getting the budesonide formoterol dry powder inhaler. And people don't realize that you've created problems not only with the delivery device, but also because there's actually a difference in terms of the way those medications are used. So you'll probably remember that the long-acting beta-2 agonists come in 2 major forms. You've got salmeterol and you've got formoterol. And the major difference is that both of them act for a long time, but the onset of action of formoterol is very quick. It's as quick as using salbutamol, which is the reliever, whereas the onset of action of salmeterol is at least half an hour. So the benefit of a formoterol-containing inhaled steroid LABA combination is that it can be used as your controller therapy, but it can also be used as a reliever therapy. And that is the basis of what we call smart therapy, which is most commonly used with the dry powder inhaler formulation, although there are also now formulations that are available in metered-dose inhaler. And it's a class effect, so there's no reason why it won't be applicable for one to the other. And in that use of therapy, you use your inhaled steroid LABA combination either just as required or as a regular daily therapy or twice daily therapy with extra doses of the same medication given whenever you are tight. And it's a very, very attractive therapy. And in fact, it is the preferred therapy in countries and in settings where cost is not much of a factor. There's a small increase in cost between the formoterol containing medications and the salmeterol containing medications, but it's not massive. And in fact, in the adult guidelines and increasingly in children, it seems as if the budesonide formoterol dry powder inhaler is getting a lot more used. But then, as you point out, the one problem is that you do have this problem in terms of decreased delivery. So strangely enough, in the most severe patients, I actually still like to use a LABA ICS containing medication that is available in a pump, no matter what it is, that you can give with a spacer. And then, if necessary, giving the combination therapy as a reliever, or alternatively, using an additional puff of that combination therapy with every puff of your short-acting beta-2 agonist.
Right. Thank you very much. I'm just checking. There's no questions brewing at the moment in the chat. And there's no hands up, so that's great. Excellent, and I'm always very happy when we run very well on time. I don't know if you've got a last few words of wisdom, and when we send around the video, I will put the link to the Allergy Foundation in there. I was just looking at your website and struggling to find the actual videos. I got some great leaflets.
Right,
but maybe
that's because those videos aren't on the website yet. Well spotted. I will tell them to get them up within the next day or two, because we are trying to get people to see those videos. But yeah, please do look at the website. There's so much information that is useful both for doctors as well as for patients.
Yeah, so that'll be great. So what we've done is we've got a few videos, but it might be better to actually use some South African ones, all with these terribly American accents. And then what we do is we've got little QR codes on our tables with patient leaflets. So a lot of patients do have smartphones, and we literally can get them to scan the QR code, or we have those videos on our own phones that we can actually show the patient a video of how to use the inhalers. Because I sometimes find as doctors, we don't always have the devices to demonstrate it properly. And it's sometimes very nice to have those videos available in the actual consulting room. So
absolutely.
I will send those out.
Absolutely.
Excellent. Thank you very much. That was great. And we hope to have some further talks from the Allergy Foundation. I think
absolutely we can talk about all sorts of interesting things, common things: eczema, urticaria, angioedema, anaphylaxis, asthma, rhinitis, all sorts of aspects of things, very common conditions. And I really think your organization is awesome and is doing a lot and has got such a valuable role to play. So it's wonderful to be able to contribute in some way.
Right. And I just noticed there was a question about spaces being available you were saying yes. So also spaces at the moment, they go also through phases, but at the moment we don't have nebulizing liquid. We don't have nebulizing, we don't have salbutamol liquid at the moment in our hospital. And what we do have spaces. So we at the moment not nebulizing anybody, we're using spaces.
Excellent. That's great.
So they are available, and they do come and go. Thank you very much. I'm going to say goodbye to everybody. Remember to put your names and MP numbers in the chat if you've not yet done so, but we will make the recording available as well on the Rudasa YouTube channel. Thank you very much, Prof, and we will see you again in the future. All the best.
Cheers. Thank you.
Bye-bye.